Yeah. Good evening to one and all. On behalf of API and ICPI, heartily welcome one and all for this update on monkeypox virtual program. All delegates who have joined virtually from whichever place to learn from the esteemed faculty. I welcome all the office bearers of API Karnataka, Patron Dr. Maya, Chairman Dr. Rajshekhar, Secretary Dr. Vishwanath, Dr. Ravi Kirti, Central Mid-Zone member, and all the API members from all over the country who have joined. I welcome our guest of honor, Dr. P.S. Shankar, Professor Emeritus, RGHS Bangalore. I also welcome Dr. A. Muruganathan, past Governor, ACP India Chapter, past Dean ICP, past President of API, and so many other organizations who needs no introduction. I welcome our today's chief guest, Dr. Girish Mathur, President-elect National API from Kota, Rajasthan, a great academician, researcher with many publications nationally and internationally, received many awards and fellowships, dedicated to API and liked by all in API family all over the country. I welcome our guest speaker, Dr. Raman Gangakhedkar, a Padma Shri awardee, former head division of epidemiology and communicable diseases, ICMR, New Delhi, and director in charge of National AIDS Research Institute, Pune, our own faculty who never said no to our earlier invite. Also in updating earlier webinars on COVID-19 in spite of his busy schedule. That speaks about his dedication and passion towards academics and teaching. A great researcher, scientist who has held many positions in past and held key role in COVID-19 pandemic as an advisor to Government of India, Ministry of Health, New Delhi. I also welcome our today's panelist, Dr. Suresh Kumar, a close associate of me, a dynamic personality in infectious disease from Apollo Hospitals, Chennai, a great name in the country with many publications and received many awards and honors, who is a passionate to teach, participating in most of our webinars, framing guidelines, and heading task force in Apollo Hospital, Chennai for infectious disease department. I also welcome our today's moderator, our own faculty, Dr. H. Basavanagaudappa, Principal JSS Medical College, Mysore, who has taken JSS University into a national name of medical science, a great academician, teacher par excellence, loved by all medical fraternity and students community, a humble man. On this occasion, I salute the COVID-19 healthcare workers for rendering their untired service to COVID-19 patients in spite of so many hurdles in the past, anticipating the fourth waves. Let us not waste the time by reading their CV profile, which runs in pages. Let us utilize time by hearing and exchange of knowledge with them in their respective specialty. As more than 100 delegates who are registered from many states, making a national event. The advantage of virtual meeting, which COVID-19 pandemic has taught a new normal life, that speaks how powerful the faculty is in their specialty. Now we have a formal virtual inauguration.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Shubham kurutvam kalyanam आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम्.
Now we are virtually honoring all our guest faculty for their tremendous contribution to their work done in their respective field in the country. Now I request Dr. P.S. Shankar sir to address the gathering. Over to you, sir.
Thank you. Thank you. Dr. Girish Mathur, Dr. Gangakhedkar, Dr. Basavanagaudappa, Dr. Suresh Kumar, Dr. Muruganathan, Dr. Maya, Dr. Rajshekhar, Vishwanath, with Ravi Kirti, Sangram, and colleagues. We have assembled here for an update on the current topic of monkeypox. I am happy Dr. Mathur is amidst us. Long back I had visited Kota, and now I am happy to welcome him amidst us. Our domiciled citizen, Dr. Muruganathan, is here. The doyen in the field, Dr. Ganga Kedekar, is with us to enlighten on this new topic. I welcome my colleagues from my state. Monkeypox is a rare zoonotic infection caused by the monkeypox virus. It is highly contagious, infectious disease spreading through close contact and presenting with symptoms similar to smallpox, but with less clinical severity and contagiousness. And looking at the surge of the infection in 78 countries, the World Health Organization has declared monkeypox as a public health emergency of international concern. The condition, which was endemic in the Central and Western Africa from 1970 till recently, it has spread to different non-endemic countries through Europe. India has accounted for 9 cases till now, 5 in Kerala and 4 in Delhi, of which 3 are from Nigerian nationals, including a woman. And 1 death has also occurred in Kerala. The condition, which spreads through animals, has changed its mode of transmission and is spreading from man to man through very intimate contact. This has made my good friend Dr. Ishwar Gilada to name the condition as a human pox. And middle-aged persons appear to be more at risk for monkeypox, and it begins with prodromal symptoms. There is lymphadenopathy, macular rash is noted on the face, palms, and the soles that takes a spread in a centrifugal fashion. Rashes may be found in the oral cavity, genitalia, conjunctiva, and trunk, and the macular eruptions pass through sequential stages of papule, vesicle, and pustule, simulating the rash of smallpox. Within a week, the pustules get dried and undergo crushing. A person is considered contagious until all scabs have fallen. So the monkeypox itself is usually self-limited disease with symptoms lasting to 2 to 4 weeks, and the persons who are infected should be isolated and must be managed. It will facilitate the prevention of the spread of the infection, and there is no proven specific therapy. Contacts are to be monitored daily for the appearance of the clinical features for a period of 21 days from the last contact with a patient or the fomite during the infectious period. Good hand hygiene has to be practiced after coming in contact with the infected persons or animals. Smallpox vaccine is likely to offer protection to monkeypox infection, as both etiological agents are closely related. Though pandemic preparedness has been made, there is no need to undergo or undertaking the vaccine. And even the country has to step up surveillance, spread awareness, and ensure that the risk groups are not stigmatized. And we are eager to hear from the experts on this topic. I am happy to associate myself with the inauguration, and I wish the program all success. Thank you.
Thank you, sir, for your kind words of wisdom. Now I request Dr. A. Muruganathan, sir, to address for few.
Good evening, my dear brothers and sisters. It is always a pleasure to attend Dr. Sangram Prada's program. And he, I don't know where he got, probably he always say it is infected enthusiasm from me. And now he's overtaking me. He's doing a lot of programs on all subjects. So, and the whole medical academy along with Sangram, API, ICP, we are doing a lot of updates and programs and needed programs. Another advantage, whenever Shankar speaks before me, Shankar will cover all the points. He will not leave any point for the speaker to speak also, because he has given so many statistics, so many background, and in an excellent way. That is a greatness of a great teacher who can speak without any problem. So I think Shankar has made the context about monkeypox. My dear brothers and sisters, I'm very happy you are going to have a very dynamic leader for API. My brother, Dr. Grease Mathur, very simpleton, very humble man, very pious man, and as I said, he's my brother. So API is going to have a dynamic year this year with Grease Mathur at the helm of affairs, and he also is a very knowledgeable academic person. And I just want to felicitate the speakers, including the Suresh, who is always in our team in the military and my military army. Suresh is one of the major general to disperse knowledge, and he is there. And only thing is, we always say infective agent, so and so disease spreads through mosquito, so and so the disease spread from tick-borne. Now we have to blame ourselves. Many diseases now started spreading through men or human being. So human being is the infective agent. So no more we say through dogs, through mosquito, through animals, through monkeys, through things. Now we have to say infective agent is doctor. I'm sorry, even doctors, even the human beings. So the best thing is you always follow preventive measures. Prevention is better than cure. And thanks to the science, every infection now we have vaccine, we have so many other good hygiene. I think the best vaccine for any disease is education, education, education. So if you know about the disease, you can prevent. And our Indian culture is so good. We always say namaste, namaskar. We don't shake hand. So this is the way you have to treat and greet, so that the message will spread. Like you should not shake hand. You should not spread the infection by contacts. So I think prevention is better, and hygiene. If you practice hygiene, you have to practice throughout the life. It should be a habit now, so that in the future also there will be so many fox may come. As I said, monkey fox, dogs fox, so many fox may come. So all these things can be prevented only by the personal hygiene, and if you know the education about the disease. So my take-home message is, for any disease, the best vaccine is education, education, education. And that's what Sangram and we are all doing to the public as well as the doctors, updating them and sensitizing them. I wish the function all success. All the dignitaries on the podium, I wish them all a very happy and healthy life. Take care, stay safe. Over to Sangram. Thank you.
Thank you, sir. Thank you for your words of wisdom. Now I request our chairman, Dr. Rajshekhar, to address the gathering for a few minutes.
Good evening, one and all. Respected the organizing committee of this event, today's webinar, especially Dr. Sangram Biradar sir, who has taken a lot of interest. So on behalf of APA Karnataka chapter, we would like to thank him, and also, of course, to with ICP, there's an academic wing of APA, is doing a good job in association with them. So respected chief guest, Dr. Girish sir, guests of honor, and speaker, Dr. Raman sir, and my dear friend and good friend and chief moderator of today, principal Dr. Basangada, JSS College, and also the panelist, Dr. Suresh. So I don't want to talk about monkeypox. Everything has been detailed by our Dr. P.S. Shankar sir. Only thing I want to tell is it a STD or not? That one has to be important, because the CDC has emphasized the importance of reducing stigma in communicating about demographic aspects of monkeypox with regards to gay and bisexual men. Though there is no cure, of course, vaccination, monkeypox vaccination is there, and regular hand washing and avoiding animals. These are the basic things we should follow, and also the role of antiviral drugs like Cidofovir. So definitely our speaker is going to enlighten us in detail about this. Again, I thank Dr. Sangram Biradar for giving this opportunity for API Karnataka. Thank you, sir.
Thank you, sir. Thank you. Now I request our chief guest, Dr. Girish Mathur, National API President, for your inaugural address.
Thank you, Dr. Biradar. A very good evening to all of us. It's my immense pleasure to be a part of today's scientific event organized by Karnataka API, ICP, and Hall Medical Academy. I am grateful to organizers, especially Dr. Sangram Biradar, Dr. Ravi Kirti, Dr. Vishnath Krishnamurthy, and Dr. Rajshekhar for inviting me at this event. It's a pleasure as well as honor to share the platform with Dr. M. Maya, Dr. P. Shankar, and my elder brother, Dr. Muruganathan. While the wounds of COVID-19 are still raw in everybody's mind, the threat of another outbreak is giving jitters to medical fraternity and society as well. We have a very distinguished faculty to discuss the monkeypox today. Dr. Raman Ganga, Dr. Suresh Kumar, Dr. Godappa. My regards to all of them. I again thank the organizers for inviting me to today's event, and I wish all the best to the success of the program. Thank you so much.
Thank you, sir, for sparing your valuable time. Now we move on to the scientific session. I request Professor Dr. Raman Ganga to deliver talk on update on monkeypox. Now I request Dr. Basavangadappa to take over for further proceedings, as Dr. Ganga sir is already introduced. I request all the attendees to type questions on the chat box. Over to you, Dr. Basavangadappa, sir.
Good evening, everybody. Thank you, Dr. Sangram Biradar, for creating this opportunity, inviting me to moderate this session, which is very hot topic. Everybody is eager to know what's happening, what would happen in terms of monkeypox, and everything has been already concisely briefed by P.S. Shankar to start with, and then Muruganathan and our chairman, and then also the president of API. I will only leave it to Dr. Raman to highlight the overview of monkeypox, and then we'll take up the questions as they come on. And once his presentation is over, we will open up the chat box and try to answer them. And also we'll request the panelists to be ready to give a helping hand in the clarifying certain doubts and queries that are raised. And we will take up the questions from the panel as well as from the chat box. Over to Dr. Raman, sir, to make your presentation on monkeypox. And thank you, API Karnataka, as well as Sangram, for creating this opportunity, which is very badly required. Everybody is eager to know what's happening currently and what would happen with this infectious disease. Thank you. Dr. Raman, sir, you can start your presentation. Request all the participants to please type your questions in the chat box.
Am I audible now?
Yes, sir.
You
Yes.
are audible, sir.
I thank Dr. Biradar and API Karnataka to provide this opportunity to talk on an issue which is an emerging infection, re-emerging infection for that matter. Now, while we try to understand more about monkeypox, I must always say that Dr. Shankar's summary was excellent. Now, what perhaps you might find when I speak is what we don't know more than what we know about monkeypox. Now, let's try and go ahead and learn about the same. Now, when we talk about monkeypox virus, it's a double-stranded DNA virus that belongs to the family of viruses, which is pox viridae, which had smallpox, cowpox, buffalo pox. All these viruses are closer kins of this particular virus. It's a brick-shaped envelope virus with a size of about 200 to 250 nanometers. The human monkeypox infection, as was already told, was a zoonotic infection to begin with. It has three different clades. Clade 1 is what was seen in Congo, which is a more virulent strain per se. Clade 2 is what is seen from West Africa, and clade 3 is what we are currently observing in Europe. We'll try and learn about them a little more. Now, when was it detected? It was first detected and isolated in Denmark in 1958 from lab monkeys, which were brought in for polio-related experimentation. But there's one thing which we must remember. The monkeys belong to Macaca mulatta or Macaca fascicularis genus, which essentially meant that these are the ones which are actually present in India. Now, not every type of monkey is present in India, but Macaca mulatta is the most common kind of a monkey that you see in India. The first reports of MPXV causing illness in human beings came from Congo in 1970. And this was endemic in Congo, Nigeria, and certain parts of Central and West African countries until then. Interestingly, the total number of cases reported between 1970 and 2000 were very small. They were almost less than 100, whichever way we look. So this doesn't tell you full magnitude, mainly because it is possible that the healthcare infrastructure was small. the reporting that had to be done into journals perhaps did not occur as commonly, but the numbers were pretty small, whatever was being reported. But suddenly in 2005, we found that the numbers increased dramatically. And one of the issues that comes around one's own mind, that why did it take so much of time? Can this be attributed to discontinuation of smallpox vaccination? Because we know smallpox were eradicated in 1970s and the vaccination was also stopped. And this particular smallpox vaccine tended to provide us cross protection against monkeypox virus or any other virus that belong to this poxviridae family, which essentially means there is a room to think that pox viruses have been waiting, to attack human beings, because there was this smallpox vaccination earlier was providing us some kind of protection, which unfortunately is now lost. The biggest jump in numbers has been observed in 2022. From May 22 to today, you find that close to about, I'm sorry, this is a typo, more than 25,000 cases have been reported in the world today. And moreover, 70 countries are non-endemic countries. And therefore, there is a fear as to why this particular virus is rapidly spreading all across. What would be the reason for such a rapid spillover? One must remember that animal to human spread mostly occurred through bushmeat. Bushmeat is something which is dead wild animals, wherein people tend to touch those animals and then consume. It leads to transmission of these monkeypox viruses. And what is important to remember, that bushmeat was detected among travelers' baggages far often in Europe, which we will see subsequently. Reflection of sexual network in a global village is perhaps important issue for us to understand. The earlier, it is also possible that our sexual networks tended to remain small. Now, since it has become global village, and you are suddenly finding that the sexual network has enlarged, it is no longer one that the European continent was spared or American continent was spared, because their contact with the African population was lesser. You find suddenly that a spillover has occurred, which may be a reflection of sexual networks between Africa and Europe at this point in time. Mutations are unlikely to be the cause of this particular spillover, which we will also try and see subsequently. If you actually look at illegal import or carryover of bushmeat at airport among travelers in Europe, there have been multiple studies so far. One in 2010, then in 2021 and 2022. You suddenly find that if you look at the amount of bushmeat that was actually captured by the authorities, you find that in 2010 it was almost 5 tons. In 2018 to 11, it was 8.6 tons, and now it's close to about 44 tons annual kind of a bushmeat that is going into Europe. Naturally, there are different cities where bushmeat is considered as one of the delicacies per se, and people tend to pay huge amounts, so it is illegal. Naturally, you find that if bushmeat was the source, from where we used to contact this monkeypox virus, even bushmeat is traveling in larger amounts in Europe. Perhaps it could also be one of the reasons why it spilled over into Europe. And what is also important, if you actually see, in 2013, close to about 100 billion euros bushmeat was actually taken into Europe. And it is estimated that today, because of stringent rules, perhaps that amount has gone down. It's about $38 billion worth bushmeat that tends to go into Europe at this center. Now, could it be a reflection of sexual network? One must remember that being an MSM in Africa is one of the most stigmatized, belonging to a stigmatized community per se. And that's one behavior which is highly stigmatized in Africa. But HIV programming perhaps has destigmatized the whole thing to some extent. And naturally, when that happens, people tend to expand their networks, and when expansion tends to occur, perhaps it has led to a spillover that can occur elsewhere. Now, if you try to see, would these genes be important for that particular purpose? If you look at the clades that we have, which you see under the figure of A, where different colors, yellow, red, they tend to talk about different clades that are there. You find that clade 1 and clade 2, they tended to have smaller phylogenetic distance between them. But when you look at clade 3 and clade 2, they have a very large difference between 2 and 3. Now, which essentially means that perhaps this clade 3, which is seen in Europe, is evolving very rapidly. And this may be a reflection that a virus which earlier used to only get spread accidentally from animals to human being, now is trying to adapt into human bodies for human to human transmission. If you look at European clade, it is B1, which is spreading very rapidly, as we tend to hear. If it comes to Indian clade, fortunately, we have only A2 clade so far, which is a less virulent clade that belongs to clade 2. And that's something which is an advantage for us as of now. But one must also remember that this is a global village. It is possible that B1 also can spill over in India very quickly. When it comes to animal and monkeypox viruses, this particular monkeypox virus has been isolated or has been found among 40 different animal species, which include squirrels, mice, rats, monkeys, and porcupine. So it has also caused few outbreaks in zoos in the past. What we need to remember that there is lack of clarity about animal reservoir. But one of the studies which tried to look into this particular issue, they feel that perhaps squirrel, though there is no direct evidence to that effect, squirrel is more likely to be an animal reservoir, and the mode of transmission, perhaps in animals, is more likely to be respiratory. We still do not know how it spreads among animals which are wild. Though if you actually look at the clinical manifestations that you see among animals, you find that skin lesions are also seen as commonly as we see among human beings. Though this may be, if you have 40 different animal species which can be infected by this particular virus, it may be a good news for scientists, because you can use many different animals as animal models for doing experimentation to discover drugs or try and test the vaccines per se. But it may not be a very good news for others, because this virus can establish itself in animal hosts, such as those which could be pet animals or rodents per se. And if it can easily establish itself, perhaps it can become endemic in any country, because in that case, it is difficult to take out this particular virus from animals. Transmission, if you actually look at transmission, that was reported among prairie dogs. Prairie dog is a misnomer. It is actually a squirrel. The prairie dog is something which is a wide pet kind of an animal which people try to keep in their household. There was one infected prairie dog which was brought in USA, and there were 11 individuals in their own family. And what was found that due to direct care, bite or scratches, people got infected by this particular monkeypox virus, because the virus, the animal, the prairie dog, the squirrel, was actually infected by it, and 6 individuals acquired this particular infection. One of them had skin lesions that started from exposure site, and the median time to resolve these lesions was close to about 12 days. 6 out of 11, that is most important for us to remember, 6 out of 11 had received a single dose smallpox vaccine in the past, which essentially flags off one issue. Would this vaccine actually protect us against infection, or would this smallpox vaccination probably try to help us to develop reducing the complication or death as a risk that we still do not know at this point in time? How is it transmitted? When it comes to animal to human, you find it's a direct contact with the infected animal. its bite or scratches. When it comes to human, there is a direct contact with infected body fluids, the skin lesions, including their scabs. Indirect contact through fomites perhaps is as rare as one can imagine. Though a respiratory route has been indicated, inhaling the virus from scabs is being talked out. To my mind, it's rare because even if you look at the kind of epidemiologic picture that you see about this infection, you realize that the number of people who may be coming from one family with infection, it tends to be small. If there is only an index case in the family and others don't get it, it essentially virtually rules out that respiratory route may be a common route for acquisition of this infection. Vertical transmission has also been reported. In one case, it was confirmed case that it was vertical transmission. The baby that was born was found to have monkeypox, but there were 3 possible cases which died, one by stillbirth or others were aborted in Congo. So do we know the transmission efficiency of each of these routes that we discussed so far? We do not know. The severity of exposure is something which is very difficult to estimate. To come out with some kind of figure related to transmission efficiency, but over a period of time, perhaps in a few months' time, we should be in a better position to know about transmission efficiency. Do we know the secondary attack rate? Secondary attack rate is one, like if I am found to be infected by monkeypox, what is the risk? What is the rate at which I might give this infection to somebody in my own family? It is reported to be close to about 9%, but we must also have a caution in one's own mind that the same family of 11 where they were exposed to prairie dog, you find that there were 7 cases which occurred in the family. So there is a propensity which could be higher. We don't know as yet, but so far the reports are that the secondary attack rate is far lower than what would imagine. It's definitely not something that you would expect with any respiratory mode of transmission. It's only about 9% at this juncture. Do we know about R0 of MPXV? The only thing that has been calculated so far with respect to R0 value, you find that currently in Europe, it is estimated to be 1.6, which essentially means it can spread among the community wherever it is spreading. But if you move apart from MSM, if you look at other populations, it's far lesser. As of now, it would be anywhere between 0.5 to 0.75, which essentially means this explosive outbreak is unlikely to occur as of now in other communities, though we must remember that we could be surprised as the time passes by. Do we know the viral load in different secretions? Yes, we know the skin lesion has the highest viral load compared to pharyngeal region. If you actually look at one of the studies where they tried to estimate the viral load per se, you find that the CT value in skin swabs was far more compared to that you find in throat. And if you look at the CT value, that tends to exist in anal swabs. It was also high enough. So essentially, what we must remember that the implication would be that the likelihood that the infection can spread through oral route or saliva is perhaps lesser compared to what you might see by direct contact with the fluids of the skin lesions. Now, incubation, when you think of incubation period, it is between 7 to 13 days. And once the rashes are likely to emerge in 2 to 3 days time, you will find that they tend to last for about 2 to 3 weeks period per se. Typically, a patient presents with fever, painful lymphadenitis after 2 to 3 days of the incubation period. There is local lymphadenitis to begin with, which tends to become generalized over a period of time. Within 3 to 4 days, the fever develops with rash, and that is macular. And as Dr. Shankar alluded to, it evolves into a vesicle and pustule subsequently. Once the scab formation starts and the crust tends to fall within 7 to 14 days, the person tends to become non-infectious at that juncture to others. Pediatric population may have rashes in non-genital regions, especially face and extremities. There appears to be two distinct patterns of clinical manifestations, though in children, you are finding that most often the rashes tend to be in non-genital region. And since this is seen more among MSM population, you are seeing those present in genital region per se. This is how the lesions tend to look like. If you look at the clinical picture that tends to exist today in Europe, you find 95% of them. This is one of the largest series that has been reported from Europe, where more than 500 cases of monkeypox were seen in different centers. This was a multicentric kind of a study. 95% of them, they had skin rash, about 62% had fever, and 56% had lymphadenopathy. And we see different frequencies for pharyngitis, headache, lethargy, myalgia. But these are very common kind of symptoms that are generally noted. And once you want to diagnose, there is one thing which we must remember. From where should I diagnose? If you see that 97% of swabs that have been taken from skin or anogenital lesion, they turned out to be positive for monkeypox lesion. So which essentially means that should be a site for preference for taking such samples per se. So anogenital area it's a little surprise, but it may be only a reflection of MSM population that we are getting it more compared to rest of the areas at this juncture. What is the differential diagnosis? You could have chickenpox as one of the issues, especially among children. Herpes simplex, that's one thing which we know it can occur around genitals, and that can confuse you with respect to this diagnosis. Secondary syphilis, which is far lesser at this juncture in India, but you still are likely to see such cases. We have to keep that at the back of mind. Smallpox, we currently don't have to worry about it. Now, in Congo, they wanted to do a surveillance for monkeypox. So what they did was they mobilized the entire healthcare machinery, and about 2,000 suspected cases were then informed by the surveillance network. But they realized that when people were referring those cases, there is something which is probably wrong in the whole process. And when they started testing them, they found almost 50% of those who had actually monkeypox, monkeypox-like lesions, had chickenpox, which was confusing the workers. We have to keep that at the back of mind when we do surveillance, because it is possible that the test yields will come down because of such kind of mistakes per se. Now, if you actually look at the mucosal lesions, where they occur, perhaps they tend to reflect the kind of sexual identity or sexual practices that a person tends to adopt. If you look at what is seen in Europe now, you have anogenital only in 68% of the people. If you look at oropharyngeal, there 23% of these MSM had oropharyngeal lesions. Anogenital and oral was seen in 7% people. Nasal and eyes was seen hardly in about 1% setting. So it is also likely to give you a lot of clue with respect to what kind of identity, sexual identity or mode of transmission through sexual intimacy might be prevalent in such circumstances. Now, the same individuals were also tested for STIs. And classically, what are we seeing here? At close to about 29% of those who were tested, they were found to have STIs of different kind, which essentially means it has two reflections to my mind. We still do not know whether this is a sexually transmitted infection. And we still don't know that if it is a sexually transmitted infection, in presence of another sexually transmitted infection, does it increase the transmission efficiency of this particular virus per se, as we have seen in HIV? We may have to wait for some time to take a call as to how does it impact on monkeypox virus per se. Right? Is monkeypox an STI? We know seminal fluid in 29 out of 32 samples that were tested for this virus was found to be positive, PCR positive. However, we all must know and we must recall that RT-PCR positivity does not reveal whether the virus is alive or dead, and therefore we need to reflect on one issue, whether this is a replication competent virus, and this can only be proven if we do virus culture studies. So far, there are no virus culture studies that have been done. So the robust evidence that you require to say that this is STI perhaps is not available as of now. But intuitively speaking, it would not be a big surprise if it eventually turns out to be a sexually transmitted infection as one of the modes of transmission. No matter what we know, the current pattern tends to suggest that it may appear as an STI given the significant proportion that also tend to have other STIs, and the virus has been detected in the semen. 95% of the cases in Europe are reported among MSM. And naturally, what happens when you talk of MSM, one must remember we cannot forget HIV among them. 41% of them are also concurrently infected by HIV. So you have a co-infection. You have HIV as well as monkeypox. Now, would it lead to worse outcomes is a question that we have to ask to ourselves. If you actually look at the study, it tends to tell you that 95% of those who were HIV infected had plasma viral load that was less than 50 copies. None of the patients in that entire study population actually succumbed to this particular infection or had major kind of complications which may require major hospitalization or some kind of handling for major morbidity per se, which essentially means if people adhere to their ART and are virologically suppressed, perhaps it may not lead to severity, increase in severity of this particular illness, but we may have to wait because it is possible that we still don't have sufficient data to talk about this particular natural history among those whose viral loads are not suppressed. We still do not know about that part. But at least there is a hope that given that NACP is focusing on virologically suppressed population in whichever groups, whether it is MSM, whether it is sex workers, or whatever group we talk of, perhaps we are better off in a way when we are going to handle this particular infection. The case fatality rate is extremely low. The current data perhaps it tends to suggest in 2022 that only about 10 people out of 25,000 that have been reported so far have succumbed globally, which is very, very low figure. The death, whatever has been reported in the past literature, is likely to occur in the second week of this particular illness, and most often it is due to encephalitis. There is only one death in Kerala that has occurred in India so far. This was a 22-year male returning from UAE. He did not receive any treatment in UAE, and then he came back to India. He is suspected to have infectious mononucleosis, and he died when he was put on ventilator. He was also Epstein-Barr virus positive, but we still do not know the final diagnosis. It is still possible that he may have had succumbed to monkeypox virus per se. But the worry comes from Spain. Would we say that those 10 cases that have died globally out of 25,000 is a less cause of worry? Perhaps not. The recent evidences that are coming from Spain, they found that there were two males who had monkeypox virus. Their age was 31 and 44 years, and they did not have any chronic morbidity or had any kind of immunocompromised condition, and they succumbed to encephalitis. We still do not know the exact causes as to why these two people could have died, but that's a cause of concern as of now. So future is currently uncertain to my mind. We may have to wait to see what would exactly happen. When it comes to diagnosis, we have to take skin swabs from the skin lesions and do PCR. Is there an ELISA? You have IgG, IgM ELISA that has been developed by CDC, but it is not available for use outside so far. You have orthopox virus, IgG and IgM, immunofluorescence assay. Immunofluorescence assay is something which is tedious to conduct. So therefore, the total reliance is going to be on doing PCR among these samples. Now, if you look at how this virus replicates, suddenly, you look at different sites, and when you look at those sites, you find that cidofovir would be one of those drugs that can be used because it tends to inhibit DNA replication, and this virus may not be able to replicate. But the other drug that is more talked of is something which we need to learn more about. There are certain issues when we discuss about tecovirimat. Tecovirimat is a drug that was developed against smallpox, and it was, if you look at the first publication came in 2018. The reason why people were working against it was, we all of us know that today there are only 2 labs in the world where the smallpox virus has been kept alive, mainly because you want to see that if there is a threat subsequently, if you want to develop a vaccine, you should have that seed stock available, and that's something which is added far more. But people were worried about bioterrorism event or an accidental leakage from laboratory, so they still went on to discover a drug that could work against smallpox per se. Tecovirimat is one of those drugs. It inhibits P37 protein, which is the most conserved protein in all orthopox viruses. Therefore, this drug is likely to work against any orthopox virus per se. It does not allow envelope formation after replication, so naturally the virus cannot survive. So one of the most important things that we must remember, that the only robust data that we have as of now on tecovirimat is from animal challenge studies for obvious reasons. There was no smallpox, there was no monkeypox where they could have tested among human beings per se. Now, when we say animal challenge studies, for smallpox, they could not undertake such studies, but they used monkeypox instead. But there is one caveat that we must remember, that the route of administration of monkeypox in animal challenge studies was intravenous or intranasal, and the drug was administered 4 days after challenge when the skin lesions were observed. So these conditions may differ from the human infection that we may observe. Perhaps its implication is also unknown at this juncture. All these animals were given lethal dose. Now, not every human being who receives this particular infection would have a lethal dose. Only one on placebo survived in those experimental studies that were done. And those who received tecovirimat, 95% of these animals actually survived. So it appears that the drug is effective, but we do not know the implications of some of the issues that we discussed earlier at this juncture. Now, for tecovirimat, they did different animal challenge studies and different dose ranging studies at that juncture, and they came up with the dose at this juncture, and the dose with which you have to use tecovirimat is 600 milligram BD for 14 days, and if it is children, the dose tends to vary by weight bands per se. 13 to 24 years child would receive 200 milligram BD. 25 to 40 kgs baby would receive it 400 milligram BD. And there were hardly any adverse events that have been so far observed among different animal studies or even human studies for safety that have been done with tecovirimat. Now, who should receive tecovirimat? CDC tends to say those who have severe disease, hemorrhagic disease. What do you mean by severe disease? Those who have hemorrhagic disease, confluent lesions, sepsis, encephalitis, and other conditions requiring hospitalization. Those who are at the highest risk of development of severe disease, those who are immunocompromised, those who are less than 8 years of age, pregnant and breastfeeding women perhaps should be provided with this drug. Those who have history of atopic dermatitis or active exfoliative condition, they may receive this drug. Please remember, only CDC has this access to this particular drug because it is only there in in BARDA's hand at this particular juncture. And what is important for us to remember is do we have sufficient evidence with respect to use of tecovirimat among human beings? If you look at the case series that have taken where these particular drugs were actually used, you find 7 patients in UK were treated between 2018 to 21 with different drugs. 3 patients were provided with brincidofovir and 1 was provided tecovirimat. Now, when you talk of tecovirimat, tecovirimat was found to only reduce the duration of viral shedding and illness. But you must remember the number of cases that were observed was only 1. Now, when it comes to another place where people have used recently in Europe, you find that only 12 people have received cidofovir as a drug, and tecovirimat was given to 8 people in Europe in 2022. What does this tell you? That we don't have sufficient data to talk about its own efficacy, effectiveness, or for that matter, any issue related to this particular drug. However, adverse events that have been observed so far have been far minimal, and we may perhaps not need to worry about these adverse events at this juncture. But what is the most limiting factor? The total number of dosages that are available of these drugs, we can provide it because this is only in the defense stockpile of USA. Currently, the drug is not being manufactured by the manufacturer as of now. You find that you can treat only about 17 lakh people as of now with this particular drug. We may have to wait. There is always a likelihood that there will be efforts to produce this drug more, but it all depends on how this infection spreads across and the market attractiveness that it may show for the pharma manufacturers. Now, the least studied compound, to my mind, this would have been really good for us because we can at least have an access to cidofovir. The least studied drug is brincidofovir. This brincidofovir is a prodrug of cidofovir, which we can actually use even in India. It tends to act on DNA replication. There is a modest survival benefit that has been seen in the prairie dogs during animal challenge studies, and we can use it against monkeypox virus as an off-label use. There is a transient reduction in throat viral load that has been observed so far, but there is also one report which tends to say that tecovirimat perhaps reduces it better compared to brincidofovir. The dosages also are very unclear as of now. The manufacturer says that you have to use in the dosages of 200 milligram once a week for 3 weeks time, but still it is unclear. This is one of the least studied compound, so it may be very difficult to use this compound unless we have clinical trials to back this particular drug's usage. We also know that women may get this infection. So do pregnant women get it? There were 4 cases that have been reported from Congo, where they found that of these 4 cases, there was probably vertical transmission, which was also confirmed in one of the cases where the child that was born had also got monkeypox. And others one, there were 2 deaths that miscarriages that occurred among 2 cases, and a fetal death was also observed in one of them. So which essentially means pregnancy, even in pregnant people, pregnant women, this infection can also occur. Though only a few women, including pregnant women, have been reported to be infected, we need to be careful if a pregnant woman has history of travel outside the country for last 21 days, close contact with MPXV, or exposure to exotic sick pet, as we had seen earlier. And why do we think, why at least I think that this is important, because I still cannot understand why it should only be transmitted only during MSM sexual activities and not heterosexual sexual activities. To my mind, that argument tends to not hold so strongly, mainly because the sexual intimacy may not be far too different between MSM sex and that tends to occur in uh, heterosexual population. If the pregnant woman turns out to be positive, there has to be 21 days of isolation at home without visitors. The woman should be clinically monitored for the symptoms. USG for fetal surveillance is required. If she has severe disease, then one needs to admit her and watch for preterm labor. Tecovirimat may be given if it is available, but when it comes to cidofovir, we must remember it is a teratogenic drug. So we need to be careful. We need to see the gestational age and then decide. The baby must be tested for MPXV. Currently, if you actually look at another preventive issue that we can actually use is the vaccines. There are 2 vaccines which are available and a few are in development as such. ACAM 2000 uses a replication competent virus. And when we say replication competent virus, it becomes naturally clear that providing this vaccine to immunocompromised population is likely to be far more challenging, which we will see subsequently. The Jynneos vaccine is a live attenuated MVA modified vaccinia ankara virus, and naturally it does not have the threat of putting in a different kind of infection in the host per se. Now there are certain issues like we try to remember about drugs, which we must remember even about vaccine. We know the vaccine was developed against smallpox, and there is no robust data in human beings. So the only data that we have, it tends to come from animal challenge. The route of administration of MPXV here is intravenous, intranasal, and in one of the studies it was intrathecal. And the endpoint was survival after infection. The sole reason why survival was used was because when you provide this particular animals a lethal dose of this particular MPXV, you suddenly may have only one endpoint that is available, and that is whether the animal tends to survive. But that has different issues for us when it comes to interpretation at that juncture. Jynneos vaccine, they studied it in Macaca fascicularis. They gave 2 dosages of the vaccine 28 days apart and compared it with placebo. And they challenged these animals. No, this was given pre-exposure. They challenged these animals after 63 days of the first dose. And what did they find? There were multiple studies that have been done for Jynneos in different animal settings. And they found 80 to 100% animals tended to survive the infection that came through intranasal or intravenous route, and as against 0 to 40% survival that was seen in placebo arm. So it appears as one of the effective vaccines, though we do not know what would be its efficacy in human beings per se in true real-time setting. When it comes to Jynneos vaccine, how is it to be administered? 2 dosages of 0.5 ml 4 weeks apart. The immune response tends to come after 2 weeks of second dose. There were 22 different studies that have been done so far on Jynneos vaccine because we wanted to know more about safety, at least, if not about efficacy. There were efforts to know about immunogenicity, which we will see subsequently. What was it that was important for us? Of these about 8,000 people, 7,000 were those who were smallpox vaccine naive, and 766 were smallpox vaccine experienced individuals. And there they found that the adverse events are far too rare. No major SAEs have been reported. And in animal studies, they found that it doesn't lead to fetal malformation. When it comes to immunogenicity data, they went for head-to-head comparison with ACAM 2000 and Jynneos. And if you look at the post-vaccination PRNT titers, you suddenly find that Jynneos appears to be a superior vaccine compared to ACAM 2000 vaccine per se. If you look at ACAM 2000, this vaccine is given, as we remember, we used to get it during smallpox vaccination. It's an intradermal vaccine. Scarification is done. You have to give 15 odd pricks with that bifurcated needle per se. And it's a single dose vaccine that is required to be repeated after 3 years' time. But one must remember, the vaccine has a black box warning that it may cause myocarditis, pericarditis, and a large proportion of people. It may also lead to encephalitis, progressive vaccinia, blindness, fetal death, and Steven-Johnson syndrome. And it has to be avoided among immunocompromised hosts. Now, how severe, how prevalent are they? If you actually look at how incident are they, you look at the incidents. Now, that's little scary when you want to provide ACAM 2000 per se for different kinds of adverse events that you may see. Some people recommend vaccines, especially from CDC. What do they say? If you provide vaccine, if it is given to an individual, it reduces viral shedding in terms of durations and reduces complication per se. Most common recommendation is about post-exposure prophylaxis. But still, there is some people like me also. I would think that if I provide this as a post-exposure prophylaxis, these are 2-dose vaccines. Then in those cases, would it lead to some kind of protection? By the time this protection may come, perhaps this infection would have had actually set in. Now we do not know about that part, so we still don't have a better idea about it. But they indicate that this vaccine should be given in high-risk exposures where direct contact with infected body fluids has been reported. And you may even think in terms of providing it to people who have intermediate risk. There was 3 hours of unprotected, that is without mask exposure to infected person. To my mind, I do not accept this, because if you actually look at what has been seen so far in epidemiologic data, you find that in a given house, despite the fact that there may be multiple number of people who may be staying, you do not find a large number of cases occurring as cluster. Now, if it was a respiratory mode of transmission, you would have seen, as we saw in COVID, more number of cases occurring in a family setting. And this doesn't happen with this particular infection. And then why should I consider intermediate risk as 3 hours of unprotected, maskless kind of exposure as an important issue to decide about vaccine? Only God knows how the definitions of level of exposure were arrived at, because we still don't have sufficient evidences to actually categorize them into different places. But those persons who even receive vaccines have to be isolated if it is a post-exposure vaccine that is being provided, and washed for 3 weeks' time. That's another thing which we must remember. Should we administer targeted pre-exposure vaccine? Should we provide it to people or certain subgroups at this juncture? If you think in terms of healthcare workers and lab personnel, probably that may emerge as one of the populations. But still, I feel good infection control practices or standard precautions that we talk about in HIV, if we adhere to them, we should be still better off rather than taking the vaccine. In any case, the vaccine dosages are not available as of now globally as much, because it is still given on compassionate ground in US and in certain European blocs that is being provided. While, when you handle sores and biological fluids, we need to be a little careful. Vaccine, to my mind, is still not required at this stage of outbreak in India. What about giving it to MSM population? Though this virus has been spreading only in MSM population, because we can say that confidently, because almost 98% of the cases are MSM. I am still not convinced that it does not spread among women. It's just that if there are genital lesions, perhaps the woman doesn't tell. It is perhaps a reflection of health and treatment seeking behavior among women. It could also be a reflection that perhaps these women don't turn up mainly because of this empowerment issues that we tend to have, or inequality that we tend to have in the society. We still need evidence to say whether this is STI. If we stigmatize MSM population and say that I want to do all interventions only among MSM, what will happen is the community will go underground, and it may lead to silent spread, because all of us know that bisexual population is almost 3 times higher than the MSM population that you actually classically see, and which essentially means silent spread could occur and a spillover might occur. So we should not stigmatize. We should treat all sexual exposures during our communications as one of the targets to sensitize the population, and not MSM related penoanal sex and peno-oral sex alone. Identification, what is also important for us to remember, that if we communicate that it's most of them are MSM who are getting this infection, which is not a true story in India today, but still, if there are cases that tend to occur of monkeypox, if people tend to have the first question mark, is it that this person is also MSM? Perhaps, it would be an indirect exposure of sexual identity, and people will still go underground. So we need to avoid this mistake altogether. Now, whatever we are doing, are we doing it right? Yes, we are. When it comes to the government has strongly undertaken surveillance for infection at this point in time. All those cases that appear to be suspected of monkeypox are getting isolated. If you do that, the modeling study tends to show that if 65% of these cases are isolated, you will find that the likelihood of this monkeypox leading to a major outbreak will not happen, but it may, at its worst, become endemic in the country. And the same is true with respect to which kind of population we should be trying. We should only be doing it among high-risk groups as of now, and that's something which we have to keep about. But we have more diffuse challenge. So far, the cases and the clade do not suggest predominance of a particular vulnerable group. Now, this leads to a question. If the cases still have been observed in India, does this mean that this infection had already established in India? It is possible to my mind, because as I said, the monkeys that we are talking about, the Macaca mulata or Macaca fascicularis, are the monkeys that are seen in India. So essentially, we don't know whether it is exposure to them that has led to establishment of this infection, whether it is in animal species or in human beings. So what is most important is we need to ensure that we strengthen the contact tracing as we did in COVID, and that may pay huge dividends per se. Last 2 slides to talk about the handling of MPXV patients in hospital. What should we be doing? You have to have strict adherence to standard precautions. Use of PPE can perhaps be advantageous in a confirmed case. Keep the patient in a single room and perhaps a dedicated toilet, preferably. Now, that's something which is going to be a little difficult for us to handle. If the room is shared, then the US recommendations tend to say that you should wear, both the patients must wear masks and have a curtain separating them. But I would always feel that this should be a question mark in our mind, given the fact that respiratory mode of transmission is unlikely to be a predominating mode per se. When it comes to mopping, it should be wet mopping of the rooms. You do not need special air handling, and appropriate bio-waste management, as we used to do in HIV, has to continue. If somebody has to handle patients at home, if I am one of those family members, I have to cover the skin lesions. Good hand hygiene has to be followed. Barrier nursing has to be done. Isolate that patient. And there would still be major question marks in terms of separate toilet and bathroom issues. But as the time passes by, perhaps the clarity may emerge at this center. In conclusion, monkeypox was an endemic infection and is now posing a challenge globally. It's an evolving science, so we don't understand everything about this particular infection at this point in time. India has clade 2, and only a few cases have been reported so far. If we sensitize community and involve them, and detect cases early and contacts tracing is exhaustive, we will be able to control its spread in India. Thank you for your patient listening.
Dr. Raman sir, thank you very much for taking us through the epidemiological discourse of this pox virus, as well as posing yourself all the clarities about the questions, ifs and buts about the therapy and the vaccine and all those points you have almost covered. And we have 3 or 4 questions only in the chat box, and we will take up other questions directly from the panel participants. The first question is by
Sir, before that, we will have comments from Dr. Suresh sir on the
Yeah,
topic.
you can take a comment from Dr. Suresh, the panelist,
Yeah.
and we'll open up the questions which are there posted in the chat box. Dr. Suresh, please. Dr. Suresh, you can unmute and come on and you can give your comments. You are muted. Please unmute yourself. And
Yeah, I think like previously the host was not allowing me to unmute me. Yeah, this is wonderful presentation. And wonderful presentations. All the data, almost all the parameters Sir has covered very well. What is happening in the global and what is happening right now. So it's a very good theory he provided, right? But only what are the questions we're going to deal with it. We'll answer the questions during the panel discussions. Excellent theories provided. What is current literature for monkeypox in nutshell within 30-40 minutes are covered, from epidemiology to vaccine to treatment. Everything is covered. So wonderful lecture, sir.
thank you,
Thank you,
Suresh.
sir.
Any other comments from other panelists? Dear sir, you have taken us through starting from 65 years back when it was found in monkeys, the virus prevailing in 1957-58 in the Congo and other regions. Later on, you have told us how it could have spread to Europe through the bushmeat carried through that, and then it has come to identifiable animal species through which you can the animals who can get infected. Then animal to human, then human to human transmission you have highlighted and given us a lot of clarity about the clinical presentation, variability between the pediatric population to the adult population in the form of non-genital source. The rashes are more common in pediatrics. And you have also told us the best way of diagnosing is the swab from the skin rashes. That is more sensitive method of diagnosing. And also discussed about the efficacy of so-called available meagerly tested molecules for treatment and vaccine variability. Also, you have expressed about the question mark connecting this disease as a STI, as well as you have covered the cross protection by smallpox vaccine. Thank you so much, sir, for all these information. And there are very few questions. We will just take them up. Can we have the answer from you? Chandrakala has asked a question. Is there an evidence of subclinical infection with this virus?
Not very strong one, though asymptomatic infection is known. If you do serologic studies, it tends to show you orthopox IgG positivity.
Okay.
But then we have to presume that this orthopox is monkeypox. As I said, these are too early days. The infection is so new that that clarity won't be existent as of now.
So there is another question, Dr. Jambu.
So
Raj
one
has
paper,
asked
I
a
just
question.
make it come. So I had one comment, sir.
Yeah, please.
Hello.
Yeah, please go ahead, sir.
Yeah. So actually, this regarding subclinical or asymptomatic, because the big question, because the differences between COVID and monkeypox, COVID without symptoms, asymptomatic phase, the transmission risk is high. Whether monkeypox also follows the COVID, that's a big question people keep on asking. But one study conducted in Europe, particularly what they tested, MSM populations, without they got a risk factors without any manifestations, no hanogenital pain, no hair ulcers, no skin lesions. They did the hanogenital PCR. The PCR remained positive for the patients, MSM with high risk behavior, but no symptoms. So, but Sarah has clearly pointed out presence of PCR, whether it's a live virus or whether it's a genetic material, we are not sure about it, but they demonstrated in a persons without symptoms, anogenital patients, anogenital lesions, PCR remained positive. And regarding the sexually transmitted infections, Lancet publications today came in showing even viral cultures positive in the semen. Previously, semen, the data what shared is shown 29 out of 32 people, semen positive for PCR. But now today, Lancet paper clearly shows the culture positivity in the semen. So probably the disease is tilting towards sexually transmitted infections, according to the Lancet paper right now. And as far as asymptomatic or subclinical manifestations, people demonstrated in anogenital lesions PCR positivity. But PCR positivity, I need to take a pinch of salt.
Thank you, Suresh, for adding your comments and giving some clarity on this point. The next question is, any prophylactic drug for high-risk personnel? This is the question asked by Jambu Raja. I know, Professor Raman, you have highlighted there are two molecules which you showed us. One tried on 12 patients, another tried on 8 patients. When the mortality rate, case fatality rate is only 0.0004, 10 out of 25,000. Is it worth risking to put an experimental drug on a human trial? Is the first question that comes up. Then the question of prophylactic drug is, I don't know, I leave it to you to answer this. A person who is post-exposure or a high-risk group, do you recommend any prophylactic drug? That is the question asked.
I think I made it fairly clear, indirectly clear. I would request Dr. Suresh Kumar to give his clear kind of an answer.
So definitely the post-exposure prophylaxis drugs is very limited role at this point of time. So I pointed out pre-exposure with the vaccinations. That's what the strategy Western countries are following, particularly for healthcare workers, laboratory people who are handling. The problem with this disease is the durations of the disease, particularly the skin lesions lasting for 4 weeks. So for COVID itself, when you ask the patient to isolate for 14 days initially, people are a little okay. But in the second wave, when we told 14 days isolations, people refuse to isolate. Nowadays, we are cutting down the isolation duration to 7 days. But with the monkeypox, all the lesions should heal. Till the time the patient should be isolated, otherwise he'll transmit the disease to other people. That means the patient needs to wait for some time, 35 days also. If you put 35 days of isolations, people go into the depression. Most of the people, the Lancet publications happened, the UK publications showed most of the people in monkeypox depressed because they're isolating for 35 days. That's a big challenge. So what is the advantage of this post-exposure prophylaxis drugs, particularly tecovimab? It reduces the durations of the lesions. So people who are exposed to tecovimab, we can cut down the durations of lesions from 35 to 21 days. When 21 days is very difficult for our people to get isolated. With COVID experience, I'm talking about isolating a people challenge for us. So that might help out. But pre-exposure prophylaxis with the high-risk people who have not taken the smallpox vaccinations, people has got a high-risk exposure. Even though we are insisting mask, we insisting standard precautions, but in healthcare situations, it's not possible. Yesterday, I encountered a case. The patients came from US. Typical hand-foot-mouth disease presentations, 22-year-old male, Indian, settled in US, got green card and living in California. Came to India 1 month back. Typical skin lesions, all hand, foot, mouth, typical hand-foot-mouth disease presentations with some lesions in the back and dorsum of the hand and everything. Not 100% typical of hand-foot-mouth, but still the patient has got typical thing. But what happened to this patient? He consulted 3 or 4 hospitals before came to me. 3 or 4 hospitals, no thought process. They thought about varicella, they thought about hand-foot-mouth diseases, but none of them thought about isolation, none of them thought about examining by putting a glove. Some of the people examine just asking, so they test the lesions, everything. That's what the patient told me there. So this is a big challenge in healthcare. Even though COVID created a lot of awareness about isolations, PPE, but still the awareness has not gone to the healthcare workers, particularly the nurses level, particularly the younger junior doctors there. So this is a big challenge for us. So we need pre-exposure prophylaxis for healthcare persons. Post-exposure prophylaxis, maybe the lesions soon after the exposures, if you take the medicines, the lesions can down, so you can cut down your isolation. That's an indirect meaning for me.
Thank you, Suresh Kumar, for giving that case example and also giving clarity on this point. In continuation of the same, Noni Gopal Singh has asked a question. Best time to vaccinate post-exposure person to confirm the cases. That's what he has asked. Can we have an answer? Best time to
Sir, let
vaccinate.
Sorry,
let
the
him-
question was not clear.
He has asked a question, best time to vaccinate post-exposed person. Can we vaccinate a person who is just
Best time?
contacted somebody with infection?
The dictum in the post-exposure prophylaxis. So the dictum in the post-exposure prophylaxis, whenever the organisms get into your body, it won't produce a disease next day. It will go inside, replicate, it will take time. So we are using the time virus or bacteria replicating, we need to attack it. So for example, HIV, the maximum 72 hours. So similarly, each one has got varicella, we can give little longer. Similarly, hepatitis B, we can give immunoglobulin a little longer. Each virus has got one period before it starts manifesting. But as far as monkeypox, the incubation period is slightly longer. That is why they're thinking about the post-exposure prophylaxis and everything. But ideally, whatever post-exposure prophylaxis, if taken yearly, it prevent the sequelae. It prevent the benefit will be maximum. Otherwise, the inverse is the benefit will be maximum. So post-exposure prophylaxis, we can give up to 4 to 7 days also. But as soon as possible, if you take, your benefit is maximum.
Thank you, Suresh Kumar. Then the question is, does the number of skin lesions indicate the severity of the disease? Because the 95% of the people, that is the most dominant clinical profile in monkeypox. Does it correlate with the clinical severity?
Actually, if you look at WHO classification, it tends to classify on number of lesions. And if you look at even CDC guidelines, they tend to tell you if you have confluent lesions, then the case should be treated as a case that requires teicovirine. So number of lesions, confluence of lesions is also indication of
One of the
severity.
parameters for grading the severity, right?
Severity, yeah.
Yeah. And then how do we distinguish between chickenpox and the monkeypox if you have a case confrontation? Are there any distinguishing features between them?
Sir, Suresh Kumar, sir, we will alternate.
One beautiful table is circulating in the WhatsApp group, sir. One beautiful table is circulating in the WhatsApp group. Ideally, what we do is monkeypox is a centrifugal distribution, starting from the face and going down. But unfortunately, this epidemic, the lesion is not a diffuse one. It is more of anogenital, more of facial lesions is more common. But the standard base is a centrifugal, starting from face to down. Chickenpox is centripetal, starting in the trunk and goes up. And usually chickenpox, the hands and feet involvement is bit low. But here the hand and feet involvement is more common. Third thing, the characteristic feature that differentiates chickenpox and small monkeypox is lymphadenopathy. In chickenpox, lymphadenopathy is less. In monkeypox, the lymphadenopathy is more common. So these are all the typical thing. And similarly, people say chickenpox means polymorphic lesions. One lesion is in papule, other is in vesicle, other lesion is a scab. All forms of lesions can present in the same site and same individual. But in small monkeypox, they told all are monomorphic, same lesions, and they from papule stage to vesicle. But what happened again in this pandemic, lesions also demonstrated. So this pandemic, the differentiation as far as the lesion is concerned is very difficult. It is not centrifugal. It is more of genital. It is more of facial lesions, and oral lesions more common. And second thing, the monomorphic picture is not present always. Polymorphic picture is present in this monkeypox also. But chickenpox typically polymorphic lesions, and hands and palms and soles will be spared. Lymphadenopathy is missing in chickenpox.
Thank you. Thank you so much, sir, for that clarification. Any other questions from any other panelists? Sangram, sir, do we see any questions from any participants?
There are no other questions, sir. Not much, because since the topic itself is a new one, everybody wants to learn.
Yeah.
Yeah. So since there are no much questions, any comments from any of the Rashekar or
One
Vishwanath?
question to the sir.
Yeah.
I'll ask one question to the sir. One of the CME WhatsApp group conducted by Dr. NP Singh, the group discussions how to identify sick individual. That's the questions today they posted in the group, because the Kerala individual died encephalitis killer. What is towards a sick individual? That's what the question they're discussing in a WhatsApp group I saw in the morning. So I try to ask Sad to answer it.
No, sick individuals, no, some of them tend to land up into bronchopneumonia, sepsis, and some land up into encephalitis, and those can be called as sick. There the fever, in addition to some other organ involvement, is seen, then you call it as a sick individual.
Sir, excuse me.
Is there
I
any
am
prediction they're asking, sir?
Prediction, nobody can predict, because as I said about those 2 cases in Spain which died, they didn't have anything. They succumbed to it. So these are early days. We will learn
Yes.
little more within a month's time. And there are only 10 deaths reported today in Western world. See, one thing which we have to realize is earlier the endemicity was in Africa. So not good or robust data tends to come from Africa. And this was since last 50 years. Now it has gone to Western nations, so we will have more dissection about evidences, and perhaps we'll have some robust data to talk about.
So what I would like to know, is it true it is declared as global health emergency, and also 25,436 suspected cases are there all over 80 countries? Because this is the data I got it from the recent JAPI. I think monkeypox, there's an article. So 80 countries, 25,846 is suspected or already diagnosed. And what I feel, the need of the hour is early screening, early detection, because of the frequency of outbreaks and periodic outbreaks and frequency of attacks. So I just would like to hear your comment.
Now I'll try to give my own comment and then request Dr. Suresh Kumar to give his own. I do not agree still that the outbreak actually merited at the time when public health emergency was declared, that it merited that kind of declaration. One of the reasons is this is otherwise a self-limiting illness. So we are learning little more as of now about risk of death and issues surrounding that. Second thing which we must remember, that if this is a self-limiting illness, beyond isolation of an individual, there was not much of a challenge for healthcare sector to handle. Because they have to protect themselves, but in any case, every health worker has to protect oneself, because we do not know what infection could come to us. So there was no health emergency in that way. But the sole reason based on which perhaps that decision was taken was only because it spread from few endemic countries to 70 odd non-endemic countries very quickly. But that could only be a reflection of, as I said, bushmeat consumption that was increasing in Europe, the sexual networks of MSM getting larger and larger, and that's why perhaps it has spilled over into Europe and even in MSM groups only in US. But to infer beyond that and say that it is a public health emergency was perhaps premature to my mind. This doesn't mean that it may not ever become public health emergency. It is possible, but at the same time, I thought it is premature because we have a backdrop of COVID. Now, at the backdrop of COVID, when people have COVID fatigue, you suddenly come up with one more disease which you do not see. Otherwise, people are not going to see monkeypox as much. In COVID, they heard a lot about COVID or saw on TV people dying or getting hospitalized. Now, if you push this as a public health emergency, there could be a fear that people, may lose trust on us, that these people tend to say anything. But as I say, I stand to be corrected. I would request Dr. Suresh Kumar to also, if you ask me, my only feeling is it was done mainly because WHO was alleged to take its own long time to declare COVID as a public health emergency. So this time they wanted to be defensive and declare it far more earlier than it actually required. But I could be wrong.
Compensatory overcorrection. It is a compensatory overcorrection of failure of early declaration of COVID as emergency. Suresh Kumar, sir.
Yes, sir, I agree with sir entirely there. Right now, it's not an emergency situations, but even in fact, WHO conducted 2 meetings. The first meeting in the June, they didn't want to declare emergency. In second meeting also, the panel, totally 14 members were present against declaring emergency, 6 were favoring emergency. But despite the WHO chief went in against, told it's a public health emergency. The basic idea when you inform public health emergency, what it happens, it gains importance, the testing can improve, the lot of money can come to the field for research and other purposes. I don't think so. If we are declaring public health emergency, the disease will go away immediately, or it brought a lot of funding, it needs a lot of research, it comes about. For example, the country like Africa is suffering from long 1970 onwards is suffering, 1980s onwards is suffering. Nobody bothers to bother about it. Every time the African country, people are dying. Still, the death rate is more in Africa. But once it goes to the Europe, once it goes to the US, still the number of death happening in Africa is more compared to death happened in US and other countries. Europe has hardly number of cases is bit low. But still, people are holding vaccines. People are still holding the Ticorimat. But Africa does not have Ticorimat still today. So this is a status. So if WHO says it's public health emergency, yes, research funding still for COVID, it's not happening. African countries still not vaccinated for COVID. Other people are resting for 4th dose and 5th dose. They're talking about it. So it creates awareness, it creates fund, it creates research, it creates at least try to create some uniformity. That is the purpose of giving emergency. Otherwise, it won't go away. Don't go away immediately. It needs a lot of attention. Similarly, other diseases, a lot of neglected diseases needs attention from WHO. Don't think Europe and US when the disease goes, then only it's emergency. Even Africa and Asia needs emergency.
Thank you.
Yes.
Thank you for excellent comment on that point. With that, we end this interactive program. Thank you, Raman, for such a wonderful discourse on monkeypox, and Suresh Kumar for excellent clarification on certain points. I thank Dr. Sangram Biradar and Dr. Rajshekhar, our chairman of API Karnataka, for giving me this opportunity to moderate.
Thank you everyone for
I
your
leave it back
wonderful
to Sangram and Vishwanath Krishnamurthy, our secretary of API Karnataka, who's there. I leave it to both of them. And thank you for bringing up this connected academic program.
Thank you, sir. It was a wonderful moderation. No other person would have been better than you. So before we close, we have one comment from Dr. Raman, sir. Take home message for the audience. What is the take home message on this talk?
We don't need to panic, but we need to be vigilant and observe standard precautions in our own personal defense as well as in the hospitals.
Thank you, sir. Dr. Suresh Kumar, your comment, take home message.
Same thing, sir. Same thing. We need to be more vigilant. So we need to not only treat the patients, we need to know how to protect ourselves from getting diseases. So the healthcare workers should be very careful about handling patients. Always think, what is the diagnosis? Think whether I'm going to get some infections, whether I'm going to transmit some infections. That should be keep in your mind.
Thank you, sir.
So one last comment from me.
Yeah.
So the need of the hour is, as told by the speaker as well as our panelist. So epidemic awareness, research, and preparedness. So, and of course, early detection and screening will go a long way in controlling the primordial prevention of monkeypox. Okay, sir? Right? Thank you.
Yeah. Dr. Vishwanath for vote of thanks.
Thank you, sir. I really take this opportunity to place on record my heartfelt thanks to Dr. Raman. Raman sir, we have been seeing you over the television during COVID times. The same characteristic style you were addressing the media, and I think the talk was equally good. Thank you very much for the information. I also sense my deep sense of appreciation to Dr. Basan Godappa sir, moderator for this session, and Dr. Suresh Kumar for clarifying so many of our doubts. Actually, I think very nice to have you all say. I also thank Dr. Girish Mathur, our chairman-elect API, National API, and guest of honor, Dr. P. Muruganathan sir and Dr. P.S. Shankar. And of course, my special thanks to my chairman of API, Dr. Rajshekhar sir, and our patron, Dr. Maya. And finally, I think one person I always feel, I tell him the engine of our academic activities, Dr. Sangram Biradar sir, because we all know it's not easy to do such activities, bringing the best in the fields. That's what I say always. When we have a program, You always make sure, we have the best people talking on that topic. Thank you very much, sir. I thank all the delegates on behalf of APA for joining this program. Thank you once again. Thank you all.
Thank you, sir. Thank you, one and all.
Thank
Stay
you.
safe. Good night. Good night to all. Thank you once
Good
again.
night.
Thank you.
Thank you. Thank you,
Thanks.
Vasanulappa. Wonderful moderation.
Yeah.
Thank you very much.
Thank you, sir.